This is a very short talk on what to look for intraoperatively. So all of us are quite familiar with this PA view of the lower end of radius, and all of us are able to practically see all the various radiological parameters here. What needs to be seen is when you take a standard PA view, the dorsal rim is actually distal and the volar rim is proximal because of the angulation of the lower end of radius. Sorry. And if this relationship, the dorsal which is distal and the proximal volar is reversed when you have a fractured distal radius angulated dorsally. So this is what we need to remember. Ideal views when you take for lower end of radius should be 10 degree elevated to accommodate for the elevation of or the angulation of the articular surface of the radius. So once you take a standard elevated 10 degree lateral view, then there are 2-3 things that you must look for. One is, this is preoperatively, I'm not talking about intraoperative imaging as yet. If you look at the lateral view, there is something called as a teardrop, which is seen here like this. This is a standard lateral projection. This is a 10 degree elevated lateral projection. And the teardrop forms an angle of 70 degrees with the long axis of the radius. Now this is the normal. So in a 10 degree elevated view, you look for 3 things. One is the collinearity of the articular surface of the lunate with the distal radius. So this has to be parallel to this. The teardrop should be nicely seen and it should form an angle of 70 degrees with the long axis of the radius. And the long axis of the radius should ideally bisect the lunate. So this is how it forms an axis of 70 degrees. Okay. This teardrop angle is changed when you have either a dorsal or volar angulation of the fracture. In the true lateral, the radial styloid overlaps the lunate to this extent, and the radius of curvature, which I just told about, of the distal radius must match with the proximal lunate. So this is what is changed. All these indices are changed when you have a fracture. Traction views, when done in the casualty, yesterday we spoke a lot about it under hematoma block or regional anesthesia, give a fair idea about displacement and reducibility, especially when you have a dorsal combination like this and you are contemplating whether to open dorsally or not. When it's a volar displacement, there is no ambiguity at all. One would immediately open volarly and plate it. But the question comes when you are having a dorsal combination and whether only a closed reduction K-wire or ligamento-taxis or a plate fixation is required. Now if you take a traction view, this will tell you very nicely how it is reducing and whether you really need to open and plate dorsally or not. So some bearing on the treatment philosophy can be had after a traction view using either the hematoma block or a regional anesthesia. So what is an acceptable reduction and the shortcomings of it? If you see all the papers as far as 1986, most of these fractures have an intra-articular component, and even 2 millimeters of incongruity of the radiocarpal joint is going to lead to arthrosis. Now, if your acceptability limits are so low, then it is imperative that on table we see them well, we assess them well, and we correct them well. Does a CT scan help preoperatively? Definitely. David Ring published this change of treatment plan seen in 48% of patients from close to open in 7.5. Especially useful in dye-punch depressions and occult injuries. So look at this. This was a close reduced fracture. Now, obviously, it's a volar displaced fracture, so there's no role of, or hardly any role of closed reduction and plaster treatment. And if you take the CT scan, this is how it was. So it was not reduced. We are talking of 2 millimeter incongruency, and look at this. So there was a dye pinch fragment, and a CT scan revealed that it was not really reduced, had to be revised. So what are our concerns in Intraop? There are three things. One is assessment of our reduction within the acceptable limits of 2 millimeters with standard PA and lateral, which even a standard 10-degree lateral elevated and PA view can give you. And two other things, whether the screws are penetrating the radiocarpal or the radioulnar joint. And the third, a minor but important concern, is whether the screw is penetrating the extensor pollicis longus groove, because that cannot be seen well in standard radiographs. So there are three important views which you must take when you are doing this surgery. The 10-degree elevated PA and lateral views, which almost everybody takes. And there are two other views, the 45-degree pronated oblique view and the skyline view. So if you look at this, these screws all look intra-articular. This is the standard PA view without elevation. But when you elevate it 10 degrees, this gives you a true picture. Another example, this looks intra-articular on the left, and on the right, 10-degree elevated view will tell you that it is not really intra-articular when you take the view like this. So also about the lateral view. So elevate it 10 degrees while taking PA and lateral, and you will know the real penetration. Another view which was described by Smith, Journal of Hand Surgery 2004, to assess the real hardware penetration of radiocarpal joint, which he proved by doing arthroscopy in the same patients, about 50 patients cohort he used, was this. So you take a pronated 45-degree oblique view, and this is the true view where you see whether the screws are penetrating the cortex, the radiocarpal joint or not. So this is an important view which can be easily done on the table. The third view is the skyline view, Journal of Hand Surgery 2010, supposedly more sensitive and accurate to detect dorsal screw penetration, especially the EPL groove. What happens is, when this is how you take the X-ray, so you keep the elbow at an angle of 20 degrees and fully flex the wrist and take a skyline view like that. What happens is, your standard beams, if you see on the right side, go tangential to the Lister's tubercle, and therefore you cannot see the EPL groove very well. If your screw is projecting out in the EPL groove, then you are likely to have an attritional rupture of the extensor pollicis longus, and therefore this view helps you. I have just a textbook picture of this view. If you see the last picture, this is how that view is taken, and it shows you whether the screw is penetrating or not. So these are the three important views. To summarize: traction views pre-op, standard PA and lateral view in 10 degrees of flexion, 45-degree pronated PA view, and a skyline view to rule out screw penetration. Thank you very much. I once again acknowledge the entire organizing team of WOSCON 18 for giving me this opportunity, and I invite you all for the Maharashtra Orthopedic Association annual conference next week in Pune at JW Marriott. We would love to host you.